Wolfgang, for this elegant outline of a hot topic. We have time for 3 questions. Maybe I can start. As we went out with the low molecular weight heparins, we always said no need to measure. And slowly, we started to measure in typical situations. If you had to measure, at what time would you measure, like kidney insufficiency, co-medication, at what timing after intake, and what would you do with it?
Thank you very much for this really easy to answer question. I like those. We have a very, very practical approach to such issues, and that is you can measure at 2 time points essentially, and that is either in peak or in trough. In peak, you're looking for the effect of the drug, but this is really not that what you're interested in. You're interested in the safety of the drug, and that's why in these situations we tend to measure trough levels in order to be able to detect accumulation. Those would be the patients that we would be most alert of, and essentially trying to keep them from start to bleed, although we don't know when they would start to bleed. The second population that we might be looking into with regard to trough level measurements would be patients that are on multiple drugs, where you could either have drug-drug interactions or on drugs that they might need in order to keep them from being more morbid from their cardiovascular disease, and which also induce a potential risk for bleeding.
Thank you. Questions from the audience? There is one question, Professor Vollat. In the meantime, do you check compliance by measuring levels?
I don't believe so. I think it's a philosophical question, because if the patient knows that you want to check compliance on him, he will take it the day you check it.
Right.
And he
it's
probably
like
stop,
the dentist when you brush your teeth.
probably stop doing it the next day.
Okay, Professor Vollat.
Many elderly patients with heart failure have a creatinine clearance around 30 to 40 mLs per minute. What is the critical level when you should reduce, for example, the dosage of dabigatran, which we was discussing, higher or the lower dose? 30 or 60, or which is the critical clearance?
We can't tell, because if you go back, just to make clear, any of those patients, those are all patients that came up with bleeding in that area here. So we don't know where we would have to set the cutoff in order to decide whether this patient is of higher risk than bleeding or not. We definitely know that if somebody is on an anticoagulant, he's at higher risk. But we can't give the specifics as we have them for the VKAs at the time being, where we know that the narrow range should be 2 to 3. And that's why I think it's important that, at least at the time being, it might be different 2 or 3 or 5 years down the road, but at the time being, it's important to respect the contraindications.
Other questions from the audience? As pharmacologists would like to see therapeutic and toxic concentrations. That was exactly the questions, but
say that. Sorry, I didn't hear
that. Clinical pharmacologists would like to see, that was the point, like vancomycin and garamycin in antibiotics, one would like to see at some point therapeutic or toxic concentrations.
Absolutely.
Just to translate. Stefan?
Well, thank you very much for this presentation, and it's now my distinct pleasure to introduce